Okay, so it is 2, and we will get started on our event for today. It is my absolute pleasure to welcome you all to the Patients Before Profits panel event brought to you by Gen Z, We Are the Future, and Combat the Patent Prices. My name is Emily, and I am the California chapter co-president at Combat the Patent Prices. It is an absolute honor to be here with all of you. First, I want to introduce you all to Mr. Justin Mendoza, who is the board president of Universities Allied for Essential Medicines and the advocacy manager for Partners in Health. Mr. Mendoza has many years of experience as a policy analyst and a healthcare advocate passionate about improving health equity policy, as well as advocating for affordable medical treatment. Following up, we have Mr. Jason Call, who is the candidate for Congress in Washington's 2nd District. He has been a progressive activist for the past 30 years and leads an effort through volunteer-led group Whole Washington, seeking to pass a single-payer bill in Washington state. He is dedicated to improving healthcare access and establishing Medicare for all. Next, we have Mr. Justin Lowenthal. He is the Director of Partnerships and Strategy at Doctors for America and has worked on their Drug Affordability Action Team. He is also the co-founder of Doctors in Politics, has worked extensively in health policy and advocacy spaces, focused on organizing doctors and medical students toward progressive health policy, equity, social justice advocacy, etc. Following up, we have Mr. Patrick Keenan, who is the Director of Consumer Protection and Policy for the Pennsylvania Health Access Network. He works on consumer priorities like transparency, quality, lower costs, and expanded protection, along with the efforts to address the social determinants of health, enhance Medicaid managed care, improve coverage, and increase health equity overall. Finally, we have Ms. Sneha Dave, who is the founder of Health Advocacy Summit and has spoken at the Democratic National Convention, among other venues, along with being selected as the youngest ever American Association of People with Disabilities emerging leader. She has spent considerate time and effort advocating for the unique challenges of young adult Crohn's disease patients, along with having created the first disability caucus in Indiana. Next, Ms. Angelica Duenas, who was supposed to be on today's panelist event, is not feeling well, but she has asked us to read a message for the audience. Quote, "We need to pass legislation like the Prescription Drug Affordability Act of 2015 that will allow the importation by individuals of prescription drugs from Canada and other countries. We need to establish restrictions on certain anti-competitive patent settlements known as pay-for-delay agreements, which effectively block generic drug competition. And we must allow for the Federal Trade Commission to initiate proceedings to enforce these restrictions. Lastly, we will fight to require drug manufacturers to provide rebates for drug dispensed to low-income individuals." Thank you, Ms. Duenas. Now, we will be moving on to the panelist questions for today. So my first question is, which I would like to open it up to the entire panel, is what experiences and events have brought you to advocate for better health equity policies and proper treatment access to all patients? Why don't we start with Mr. Justin Mendoza?
Thank you so much, Emily, and thank you for the warm introduction. Super excited to chat with you. And yeah, from my story of how I got involved with this, I was once a pre-medical student thinking I was going to eventually end up probably getting organized by Justin Lowenthal to do some advocacy work. But while I was a pre-medical student, I spent some time in Ghana just for a couple of months. Nothing world changing. I wasn't doing anything to help, but just was there to listen and learn from medical professionals abroad. And I got to meet a recovering patient who had HIV and tuberculosis, and she was 12 years old. Her family wasn't poor. They were a family that was of a moderate income for the area of Ghana they were from, and they had access to healthcare. But even with those conditions in place, it took her family 13 hours to get her to the best children's hospital to treat HIV and tuberculosis. And when she was there in a hospital funded by NGOs, or non-governmental organizations that had a lot of resources to bear, it was still very expensive and hard to get her the treatments that she needed for tuberculosis and HIV, two diseases that infect millions of people every single year that are not all that rare, especially outside of the United States. And yet it still took an overwhelming number of resources, millions of dollars of investments to build the hospital infrastructure, and a major push to get those medicines to actually be at her door. And for that, that entire system made me realize, well, there's a lot of broken things in healthcare. There are a lot of pieces here, from the cost of the HIV drugs to the cost of the tuberculosis drugs to how broken the supply chain was to make it hard for someone to even be able to access those things to begin with when they're not even in the poorest parts of the world or the poorest parts of even West Africa or Ghana. And so I stepped away from that and realized I want to work in policy change. I want to try to drive forward a system to where she would just have access to healthcare automatically, just like all of us deserve.
Awesome. So why don't we move on next to Miss Dave? Sorry to interrupt you. Is it only me who cannot hear her audio? Okay, while she's figuring that out, why don't we move on to Mr. Call?
Thank you. And before I start, I just want to say what it is an honor to be among a bunch of esteemed people working in improving healthcare policy, and just so happy that the youth of this country is stepping up to take control of what are some very deficient policies in this country. My journey with healthcare, and as you mentioned, I am a board member of a group called Whole Washington in Washington State. We are trying to bring single payer to Washington State in the absence of a federal Medicare for All program, and it looks like it's going to be some time before we get anything past the federal level. But my story really began with healthcare. Really began almost 20 years ago when my mother went in for routine surgery, and the insurance companies would not pay for her, would not cover her for more than a single day recovery in the hospital. She didn't feel well. She asked them if they would stay longer. They said, no, your insurance company's not going to cover you, and they sent her home. Well, within 24 hours, she was back in the hospital, collapsed on the floor of her apartment. Spent 3 months in an induced coma. Her bowel had ruptured. She had sepsis. She was on a ventilator. I thought she was going to die. And, we hadn't even had a chance to say our goodbyes. She spent 2 years learning to walk again, and she spent the rest of her life on a walker. She died early. She died before she was 70 years old. And this was a routine surgery that, had she been allowed to stay in the hospital for a little bit longer recovery, they could have caught the issue. She could have healed on the spot, and she could have gone on with her life. She was a working woman whose life was essentially ruined by a bean counter in the insurance companies who said, we're not going to pay for your further recovery. Also have a sister who has a very rare genetic condition. I don't know if you've heard of Derkham's disease. It's painful and comes along with a lot of mental health issues, because you're essentially a person who is living in pain. But because it is such a rare disease, all the treatments are experimental, and so the insurance companies aren't going to cover them. So my fight is also is certainly against the pharmaceutical industry, but it's even more so against the health insurance industry. So that's why I'm an advocate for Medicare for all. And as I said, I really think it's incumbent upon all states to try and push a state single payer program the way Canada did. Canada got its national health insurance program one province at a time, and I think we can do the same thing here in the United States. So thank you.
Thank you for the story. Miss Dave, is your audio working now?
Yes, I think so. Can you hear me now?
Yeah,
Okay,
we can.
Great. All right. Yeah, so I am super excited to be here today. I think we have some really awesome co-panelists too, so I'm really thrilled to be with some awesome company. So my journey toward advocating for better health policies, and specifically lowering the prices of prescription drugs, is because of my own journey. I was diagnosed with ulcerative colitis when I was 6 years old. Ulcerative colitis is very similar to Crohn's disease, in that it primarily affects the large intestine, but also really it's autoimmune, so it kind of really affects the entire body. So I had a pretty aggressive disease starting when I was 6, and I'm now 22. And so I've been on so many different complex biologics. I've been through all the treatment regimens, multiple surgeries. But even more so, I run the Health Advocacy Summit and its program, the Crohn's and Colitis Young Adults Network. And so we work with primarily young adults ages about 13 to 30 years old. And so for patients who are about 18 to 26, a lot of them are being financially independent for the first time, and to add in a chronic condition during this time with very, very expensive, complex medications is very difficult for a lot of our demographic. And I think historically we've sort of forgotten about the young adult patient demographic. And it's really important, I think, for our age demographic in particular to be able to not have to deal with complex systems when we're trying to just graduate from college, go to trade school, find work for the first time, navigate insurance, which is a whole beast of its own. And so also I briefly have, before I was sort of on this side of the prescription drug pricing world, I used to work with the pharmaceutical industry when I was about 18 years old. So I was on, for example, Pfizer's patient advisory board. I did some marketing campaigns with a pharmaceutical company here in Indianapolis, headquartered in Indianapolis. And I'm sure those of you who know about the pharmaceutical industry will be able to figure out which one that is. And then I also interned at Pfizer in health economics and outcomes research at their headquarters in New York City, which taught me a whole lot about drug pricing and the way that different markets work, and really how in the US we're at a huge disadvantage because we don't have a lot of policies in place, and we don't have a formal body that governs and dictates the actual value of up and coming drugs.
Yeah, it's really inspiring to hear your story about combating such detrimental disease at a very young age, and now being able to leave a group of young people against that problem. So yeah, thank you for that. Next, we'd like to move on to Mr. Lowenthal.
Hi, Emily. Thank you to Combat the Patient Prices and Gen Z, We Are the Future, for inviting me. It's thrilling to be here with this group. Great to see Justin, an old friend and friendly face, as well as meet all of you. I am, in addition to working as a volunteer with Doctors for America, I am a medical student and a graduate student in Baltimore, currently finishing up my PhD work in basic science. And a lot of the reason that I end up doing as much advocacy work as I do is just based on my academic path and what I found interesting at the time I was going through school and what was happening in the world at the time I was going through. In undergrad, I studied biomedical engineering, but very quickly became interested in bioethics and health policy. When you're young, they tend to call it being a policy nerd. When you're older and get paid for it, they tend to call it being a policy wonk. There's a few different phrases for it, but I got very heavily invested and interested in that. Right around that time was when the Obama administration and politicians in DC were debating the Affordable Care Act and debating the largest expansion of health care in a long, long time. For the longest time, it always fascinated and disturbed me that in the US we had attached the ability to get health care to whether or not you have a job, and whether or not that job is generous enough to give you health care, and whether or not when you leave one job to go to a new job, you're able to find a way to keep that care for you and your kids. And it's something that I always thought was wrong, and that I very quickly wanted to study to see it change. After undergrad, studied bioethics at the National Institutes of Health, and watched a lot of the Affordable Care Act both be implemented but also be fought at the state level. Things like Medicaid expansion and like any sort of reforms that would rein in the costs of prescription drugs, including comparative boards and things of that nature, were fought at the state level, mostly for political reasons, not for good policy reasons. And then once I moved to Baltimore, everything kind of changed for me. I started medical school and quickly saw among the patients I was seeing in Baltimore just how difficult their lives were, and how the healthcare system was not equipped, even in a place like Baltimore where you have illustrious institutions like Johns Hopkins and like University of Maryland, and the federal government just 40 minutes down the road. a city population that could not access care, that could not afford insulin, that was in neighborhoods that were not safe enough for them to go out and get exercise and stay healthy, or without any adequate transportation to get to their appointments or to the pharmacy to fill their prescriptions. And so just seeing how complex and how systemic and systemically racist and socially unjust a lot of these systems were, spurred me to, in parallel with my medical training and my basic science training, to spend a lot of time working on political change. And so that's what brought me to Doctors for America, and now to Doctors in Politics, which is kind of a separate effort, getting progressive physicians into political office. And happy to talk more about those things. But in the meantime, just thrilled to be here and talking with this crew.
Yeah, thank you for the answer, and thank you for bringing up these important issues under spotlight, which we will definitely talk about later on in the future questions. But lastly, I would like to pass it to Mr. Keenan. You have the floor.
Sure. I just want to echo what everyone said about Gen Z. We are the future, and combat patent prices, just for engaging on this issue. I think many of us have been involved with prescription drug advocacy. You see it from, a perspective of folks who may be 55, 60, 70. And so it's really exciting to see younger folks, really engaging in this. So thank you. I think my experience isn't that much different from many of the folks who have already spoken. I think the reality is that Wall Street sets pharma prices rather than Main Street. And that's a really hard lesson to learn. And many folks don't actually learn it. So I kind of was on that path. I graduated college from the time I was 11. I have asthma, which isn't a really serious disease, but I need, medicine basically every day of my life to just keep, normal and active and healthy. And, I got a job that gave me health insurance, and it wasn't until after 7 years of that job I left and, was becoming self-employed and trying to find my own insurance, realized that the patent that was on my inhaler, it was basically either I could afford insurance or I could afford that inhaler that I need every day. Because I couldn't afford both, because the insurance was about the same cost as the medicine, but the insurance came with a huge deductible that would prevent me from getting the medicine that I needed. And so that's what got me volunteering at the state level for the Pennsylvania Health Access Network. And what I realized is, there's a lot of folks that are kind of insulated from that, because either they don't have that medical condition, or they have really good insurance, so they don't worry about the cost. What I found is that, just like most Pennsylvanians, half of Pennsylvanians are struggling with healthcare costs. And I realized that I was a part of that. So really, since 2007, or since I've been at the Health Access Network since 2013, I've just realized how many different ways people struggle, just like I did, in being able to not only get insurance, but also, once they have insurance, get access to the medicines that they need. And there's real actionable things that we can do at the state level that could stop that could ensure that we have access to the medicines we need. It actually probably would help pharma, because more people would have access to their drugs, but there's a lot of resistance to these policies. So I think just that personal experience, along with seeing so many other folks struggle, is kind of what keeps me in the fight.
Yeah, thank you, Mr. Keenan. And talking about the problem with healthcare accessibility, which is an issue that almost every single panelist brought up, kind of relates to our next question for today, which is, again, addressed to the entire panelists. In the 20th century, most vaccines are considered a charity act, but after the creation of the pneumonia vaccine and its patent, prices have risen significantly. So what is your view on patenting and selling vaccines for high prices, especially in the current COVID-19 climate? So why don't we start with Ms. Dave?
Yeah, for sure. So, I think that it's a very obvious answer for myself. I think that, especially when we're dealing with vaccines, which is a basic human right, especially if it is taxpayer funded, is absolutely essential. And I also think that, the way that vaccine rollout has a lot of questionable challenges, especially in countries that are not the US, basically. The other thing too is that Operation Warp Speed, which is basically a collective of the government and private companies. So they basically were created to create the COVID vaccine and to create a safe and effective treatment. However, much of the funding for Operation Warp Speed came from the government, which also means that came from taxpayers' money. And so I believe from a recent report I read from Patients for Affordable Drugs, which I highly recommend everyone check out Patients for Affordable Drugs. They're a really incredible nonprofit, side note. The pharmaceutical industry, I believe, is predicted to make about $40 billion from vaccines alone in 2021. And the fact that we, as our government has contributed largely to that effort, both on the innovation side and the funding side, just makes it a very clear argument that vaccines must be accessible and affordable for the entire US demographic, but in addition, the entire world, because we are not the only ones who need vaccine access, and we are not the only ones who need vaccine access at this moment.
Yeah, definitely. So next, I would like to invite Mr. Lowenthal to talk about the question.
Sure, and I don't have a whole lot to say beyond what Sneha just said. I mean, that was exactly right across the board. The one additional thing I'll say is the profit motivation in healthcare generally, I think, is very morally problematic. I think it's very economically problematic. That's definitely true when it comes to prescription drugs. That's even more true when it comes to public health interventions like vaccines. We've been talking about how the COVID vaccines are what's necessary to get our economy up and running again and get us out of the pandemic. And aside from some quabbles I might have with the logic of that from a public health standpoint, it does not make any sense to then limit people's access to the vaccine that we need people to be able to access so that we can get our economy running again, so we can reduce our rates of death and rates of morbidity by making the vaccine unaffordable and making the vaccine inaccessible. And so from a moral perspective, I think it's wrong. From an economic perspective, I think it makes no sense. And from a political perspective, I think it's quite unpopular. So, we can go into the sort of inequities that you brought up, Emily, a little bit more later. That's something that's playing out right now where I am in Baltimore. And cost is not the only barrier to people getting the vaccine. And thankfully, people with the COVID vaccine have been at least a little bit more vocal and forward thinking about that. But yeah, I think all the points Sneha made, plus just the sort of logic of a public health response, makes it such that vaccines should not be something that costs the users money.
Yeah, definitely. And I would like to now direct the question to Mr. Mendoza to see if you have anything else to add to the previous panelists.
Absolutely, and I would just like to echo everything they both said was completely right. When it comes to drug prices, of course, we see every single part of the pharmaceutical industry raise their drug prices every year. Patrick mentioned earlier that drug prices are more tied to Wall Street than Main Street. It's very true. They have no incentive to ever lower their prices. Even when they do, it's a negotiated rate with one particular company or something in that realm. And that's true with vaccines. So, of course, we know that right now COVID-19 vaccines for folks in the US is $0 out of pocket, either through insurance, Medicaid, or other systems. It's a different story if you're undocumented. You could have issues getting vaccines. So a lot of states are working really hard to make sure that that's not a problem. So most folks have access anyway as they get rolled out. But also, there's two issues. One is Pfizer has already talked about selling the vaccine at $155 per dose after the pandemic's emergency status is over. And I think Justin actually has the real stats on that, so you can correct me if I'm wrong. But it's very expensive. That's what they're talking about after this. Right now, countries are paying $32 for the course of treatment on average, which is far, far cheaper than $150 per dose. So we'll see those access issues play out. The other issue is that patents are also used and other forms of intellectual property to make sure that there's not enough competition to ramp up and scale up production. So right now, the biggest problem with COVID vaccines is that there's just not enough vaccine. Right? That's why it's so slow in the US, which we're getting there. Luckily, there's some agreements and movement in that direction, and we'll have enough by May for US adults. But globally, we're talking about major deficits. Only a few countries have actually had good success vaccinating large parts of their population, and they're all rich, wealthy, white countries, to put it really bluntly. So when we look at this from a global perspective, yet again, the global north is extracting wealth and resources from the global south and not sharing because we did testing in those countries and we worked with those countries' governments. And we've learned this lesson a few times before, not only about the number of vaccines, but about prices eventually. In the 1990s, the first HIV drugs entered the market right around 96, and these drugs were $10,000 per person per year. And right around the early 2000s, folks at my current employer, Partners in Health, but also Doctors Without Borders and lots of other orgs, realized, hey, if you give people HIV drugs and they have HIV, you can help keep them alive no matter what country they live in, no matter how poor they are. And in fact, a US administrator at the time said that folks in Africa couldn't take HIV drugs because they could not tell time and did not wear watches, which was of course false. We hear that same kind of language playing out with vaccines. If you ask any of the major vaccine manufacturers, they'll tell you countries around the world can't possibly create our technology. The mRNA technology is too new and complex. But in reality, no one could make an mRNA vaccine a year ago. It's new technology. So obviously other folks can build it as well. So really, what I've been a part of with a lot of folks in something called the People's Vaccine Alliance, we're pushing for some bold political leadership. We want to see the Biden administration step up and say, we have to share this recipe, the secret know-how and the patents held on these vaccines with the world so that we can create more vaccines, mass manufacturing across the globe, and really, truly try to stop COVID. Using this as a real diplomatic moment rather than letting competition play out the way it normally does. And I think that we can do that. We learned that lesson with HIV. The US government licensed their technologies and essentially broke the patents on HIV drugs. And now it's about $50 a year to treat someone with HIV in a low-income country. We can do it again with COVID. So I do think that there's a real path here. I think that this is the right kind of conversation to have. And of course, with vaccines, patents are only part of the picture, but it's a big, important part, and it's attached to the other part of the picture. So it's huge.
Yeah, definitely. We definitely agree that COVID-19 is an issue that only if the entire world comes together, or else it's always going to be like, oh, this country is like still affected. That country still has like people who are carrying the pandemic. So yeah, definitely agree with that. So next I would like to invite Mr. Keenan to share your view on this problem.
Sure. I mean, I think everyone's kind of already talked about these things, but I just want to add some perspective here. Some people may, everyone's eyes glaze over when you talk about patents, right? It's law, it sounds really bad. And I think when you get back to the core of a patent can be a good thing if it's used in the right way. If you're in your basement developing, something that's going to change the world and you're putting every ounce of it, every ounce of yourself into that, you deserve to have that protected, right? But let's be really clear about prescription drugs. That's not what pharma's doing. They don't, often they're taking research that's already been publicly subsidized and just kind of branding it or revamping it in their own labs, right? They're not adding, all of that value to it. So do they deserve an exclusive patent? I would say, they haven't proven that they're with all drugs, unless they can say, that no taxpayer dollars have gone into it and that they've done it exclusively on their own. I think they don't kind of fit the mold for patents. But the second thing is that they've really kind of taken a good thing and created all of these problems on top of it. So they've created patent thickets or pay for delay or all of these other things that really take this good idea of a patent and make it really harmful to people and use it against people. Going back to my own example, the inhaler that I needed was supposed to go off patent in 2010. It didn't actually become generic until 2019, right? If that drug had gone off patent in 2010, I would have never been uninsured, right? And so I guess in some ways, I'm glad that patents kind of, screwed the system over, because it got me into this work and got me fired up. But I mean, again, it really is about curbing these harmful policies that the industry has exploited to kind of take what's supposed to be a good thing and really turn it against everyday folks and really keep them from getting the medicines that they need. And that's unfair. And that's something that we really should be working to stop.
Yeah, Mr. Kingdon brought up a really great point about these companies like abusing their patents, which is actually what we're going to talk about next. But before that, I would like to invite Mr. Call to end us on this question.
Sure, thank you. Wonderful conversation and leaning really in the direction of something I'm very interested in, which is politics and economy and what the purpose of government even is. I appreciate that Justin brought up that we still have a very colonial mindset in terms of dealing with the rest of the world. But the pharmaceutical industry itself is really critical to national and global health. And so when we go back to really what is the purpose of government? The purpose of government is, even if you read the U.S. Constitution, it says right there is to provide for the general welfare of the people. So that doesn't mean creation of a welfare state. It means in policies that are ensuring that everybody has access to things that are for the greater good. And I think we get such in America in particular, we get such propagandized about, if you can just work hard enough, if you just put so much effort into it, then you're going to come out, you're going to be a billionaire and you should invest. Well, the reality is, our system, capitalism, let's talk about global capitalism here. Capitalism actually strangles innovation in a lot of places. You have these giant pharmaceutical companies that have so much market power that they are able to manipulate competition out of existence. And the reality is that the US government finances pharmaceutical research to the tune of $40 billion a year. So there is so much of our taxpayer money going into just the development of these drugs that to then allow, as Patrick said, these companies turn around and slap a patent on something that wasn't even really their research is quite frankly offensive, and it is antithetical to our national and global health. So in my opinion, since the pharmaceutical industry is so critical to national health, I believe it is an industry that should be nationalized. Now, there's going to be some pushback on that, but I think that our government can produce these drugs as high a quality as any of the pharmaceutical industries they can, and they can do it for much lower cost. You take the profit out of it. I think profit should not be associated with healthcare in any way, shape, or form. That doesn't mean I don't think doctors should be paid well, and the workers in the medical industry should be paid well. But when you're talking about a CEO of a hospital or CEO of an insurance company or CEO of a pharmaceutical company walking away with billions and billions of dollars that they've, just by accidents and luck have been able to extract from the system, I just think that there's something morally wrong about that. So, it's one of the reasons I'm an advocate for having a Medicare for all system where our insurance system is nationalized. And I do believe that our pharmaceutical systems should be nationalized also.
Yeah, I definitely agree with that. And I think a lot of people will agree with your beliefs. So now let's move on to the next question for today. And this question is targeted towards Mr. Mendoza, Mr. Lowenthal, and Mr. Keenan. And of course, any other panelists who have anything to add to the conversation are more than welcome to do that. So the question is, several pharmaceutical companies have kept their drug patents after innovation period with minor modifications, otherwise known as evergreening. And this evergreening issue, despite being very well publicized, is still present in current day American politics. Some states have begun efforts to establish pharmaceutical transparency policies. However, the success rate is very, very low. In this situation, how can the government best ensure that pharmaceutical transparency be regulated, and what criteria for prescription drugs should be met to become subject to drug transparency programs? So we'd like to start off with Mr. Mendoza.
I really love this question. I think you all dove straight into the weeds, which is exciting. And I think to add on to Patrick's comments, I just pointed to him, but I don't know if he's there for everyone else. But earlier he was talking about exactly this, right? The idea that you tweak a small molecule and then you end up patenting it for another 20 years. One of the big thickets or evergreen drugs I like to point to is Humira, which is one that's, I believe it's the most prescribed prescription drug in the United States. If not, it's one of the most profitable. But it's a drug that has about 40 years of patent life remaining on it because of the massive thicket of patents around it. And it's already $39,000 per year, per patient per year. And that actually might be the 2018 number. So it actually might have gone over 40. So this is a very expensive drug. And frankly, people take it for rheumatoid arthritis. So a lot of people are taking it for that. I think actually Crohn's sometimes is one of the drugs for that. So it can be used for tons of conditions, and it is a life-saving, very important medicine. But, and I'm not saying it's not valuable, but they're just holding on to this patent and using this thicket to continue the life of their monopoly as long as they possibly can, which creates so many problems. When it comes to transparency, I think those are the types of drugs that immediately should have transparency. We should know why they're justifying raising the price of Humira every single year. And when that answer is, as we all think it is, it's because the shareholders want to see a turned profit every quarter, and you raise the price to have that profit rather than actually trying to invent new drugs, then it proves what Jason was saying earlier, that the pharmaceutical industry as it is today doesn't produce innovation. It produces these massive profit-seeking entities that just raise their price and make more profits. So I think that that's one of the key areas for transparency. The other one is anything that's government funded. Right now in the U.S. Congress, there's a bill called the TRACK Act, which would transparently report out any of the data and make it easier to find data about drugs that were funded with taxpayer dollars. And right now, it's actually very hard to figure that out. When I was doing my master's degree, I spent about 6 months just trying to track down public funding on one drug for a project, and it took 6 months. And not only me, but I had undergraduate researchers working with me. So when you look at it from that perspective, having simple transparency measures in place is a no-brainer, and absolutely will help us navigate the entire system.
Yeah, that is a great response. And I think you definitely brought up some very good points, especially about like the one drug can be as high as like 40K per year. I think that's just a little bit absurd at this point. But next, we would like to move on to Mr. Keenan and see, going back to what you talked about earlier, and see if you have any more additional points to add.
Yeah, I think that we can go beyond transparency. And that's what I mean. So one of the things I should be really clear on is that, I'm here talking at the state level. So there's Justin and Justin and other folks may have more perspective at a federal level because that's not my expertise. But at the state level, we're pushing for something that Maryland has already begun to implement, which is the Prescription Drug Affordability Board. And let's be really clear about the Prescription Drug Affordability Board. It's one of the few solutions right now that would actually lower the cost of prescription drugs when someone shows up at the pharmacy counter. There's a lot of other solutions that we can propose. Transparency in itself gives us good information, but doesn't actually lower the price. But the Prescription Drug Affordability Board steps in when drugs, like Humira or some of these other drugs, create really serious affordability burdens. And I want to be really clear that, many of us think about the personal level. You've heard my own story, but prescription drug prices don't just hurt individuals. That's the biggest form of harm that's out there, but they hurt employers, small businesses, hospitals, even our state government. So like in Harrisburg, we have these huge, crazy conversations about having to cut other programs because our spending has gone up. And in reality, drug spending is one of the biggest components of that, in our healthcare programs. It's really out of control. If we had a drug affordability board, it could look at certain drugs that are creating problems and really look at a way not to do, some people, pharma likes to call this a hit job on them and play this, poor us card, we're going to be destroyed. But in reality, the cool part about the Drug Affordability Board is it would impose what's called an upper payment limit that doesn't actually hurt pharma. As a matter of fact, pharma might be able to make more money off of a drug with this kind of upper payment limit in place because more people have access to the drug. This goes back to the idea that Wall Street is setting the price, not Main Street, right? So a drug price is really set at what gives shareholders and the stock market the best bang for its buck. And the upper payment limit would really kind of cap in certain ways, kind of the cost that folks pay for those drugs, but it would expand the market so that everyone that needs that drug could actually get that drug. And so pharma would end up selling more of these drugs, right, rather than less. And by virtue of just expanding their market rather than raising their price, which is right now what they so frequently do, they could be in a better spot. So not only would it help more folks, but it, there's the societal good to small businesses, to hospitals, to state governments, and to us, right? The people that need these drugs could really be felt. So that's a really promising state level thing that goes beyond transparency and really leads us to action.
Yeah, that sounds like a win-win. Not only do like more people get access to the drug they need, but they also have it at lower prices while the pharmaceutical companies gain more profits. So next, we would like to direct the question to Mr. Lowenthal and see what other perspective you can add to this issue.
Yeah, as usual, if you don't get a chance to go first, most of your great points have been stolen by the previous two speakers, but I'll try to add some follow-ups, particularly to what Patrick said. When I think about transparency in terms of advocacy work, there's two things that I generally think about. One is that transparency is a great first step, and transparency alone does not do the job. If the last 4 years taught us anything, it's that a lot of bad things can still happen even when they're transparent. And so we need to be very clear that transparency needs to be paired with ways for the government, whether it's states or federal or local or other mechanisms, to enforce and to bring prices down when information comes to light that we need to do something about. So pairing information transparency with the ability of a state attorney general or state legal system to force drug prices to be reduced. Giving health systems in states, both like state medical systems and hospitals, the ability to negotiate better prices and the access to certain drugs, use the access to certain drugs for their patients as leverage, so that drug companies need to be able to reduce those prices in order to have access to those patients or those customers in their case. I think the other thing, though, sort of upstream, not just in terms of enforcement downstream, but upstream, changing the incentives by which pharmaceutical companies are choosing what drugs to invest in, what drugs to produce, and to reduce the incentives to do this sort of evergreening practice. I think if we change the system by which we pay for drugs to make it reward true innovation, to make it reward drugs that are actual substantial increases in benefit for patients and not just slight changes in the chemistry of a drug. If we reward companies for responding to public health threats like COVID, like other infectious disease outbreaks, which don't have as much of a standard profit motivation attached to them, that can also head off some of this downstream issues. The other quick point I'll make is when we talk about transparency, we should be specific about what information we want to get, keeping in mind that the retail price that a drug company lists is not going to be the same price that a pharmacy buys it at. It's not going to be the same price that a healthcare system buys it at, or that CVS or Walgreens buy it, and it's not going to be the same price that a patient is going to have to pay out of pocket. There's also these middlemen, which we may get some time to talk about, pharmacy benefit managers, which have a role to play in this too. But ultimately, we need to ask for transparency at multiple levels of price setting, and then pair it with ways downstream to ways upstream to incentivize changes in behavior, and ways downstream to enforce limits on bad behavior.
Yep, definitely. That was a very great conversation regarding evergreening, as well as like patents and stuff. So now I would like to direct the conversation towards what Mr. Call mentioned before, which is Medicare for All. So the next question is actually directed towards Mr. Call, which is, as you stated, you and your organization, Whole Washington, are supporters of Medicare for All. And according to the recent poll numbers, 68% of the Americans actually support Medicare for All. So what do you believe is the biggest problem facing progressive representative in seeing medical reform policies into law? And what is actually stopping their fellow congressmen and women from supporting these impactful policies like Medicare for All?
Thank you. Well, as you know, the people who we would consider political progressives, people like Pramila Jayapal, people like Bernie Sanders, have put legislation on the table in the House and the Senate to have a Medicare for All system, which does not actually nationalize the medical industry. It simply nationalizes the insurance industry. And so you're taking a lot of the administrative costs, and you're definitely taking the profit out of insurance. Which is in the end going to be to the benefit of so many people who, I'll just give you, for example, we have 500,000 people here in Washington State who can't afford insurance. They're not covered by employer-based insurance. ACA, the Obamacare premiums are high, even when they're subsidized. And then, the deductibles that come on the back end of that, and the copays and the prescription costs for low income residents are simply unaffordable, and people end up avoiding going to the doctor. And then you see people have preventable illnesses or preventable results of illnesses that are let go. They're not treated when they should be treated early. Is much more expensive in the long run than it would be if they were just dealt with when they're discovered. I mean, that was really the issue with my mother. I mentioned that my mother had a bad surgery. Had the insurance company simply paid for that extra night or two in the hospital, she wouldn't have had 10 years and 30 surgeries and 2 years of a hospital stay that they ended up having to pay for anyway. And so going back to what Patrick said about the way prescription drugs are dealt with in Pennsylvania, you find that the corporate for-profit mindset is often counterproductive to what you would think that they're in the business for. It's very short-sighted, and they end up paying more on the back end, in addition to so many people not being effectively served with their healthcare needs. But when you come down to what is the problem, it is the corporate money in the system. It's the fact that we have a system of political financing that is heavily reliant on corporations funding the campaigns of, for instance, the person that I am running against in Washington State. He's taken over $300,000 from the for-profit medical industry, and he hasn't even taken as much as so many other people have. I mean, take my own Senator Patty Murray. She's been in office since, I think, 1994. She's taken almost $1 million from the pharmaceutical industry alone. And she happened to be one of these senators who, I believe it was in 2017, voted against the reimportation of drugs from Canada so that the Americans could have substantially lower drug prices. Corporate money in the system is it's absolutely antithetical to getting people what they need out of their government in terms of good services. I mean, and again, going back to what is the purpose of government? It is not to ensure corporate profits. It is to ensure the wellness of our population. So I would say from Whole Washington, in the work that I have done trying to get the single payer system, we had an initiative in 2018. We're going to run another initiative. We actually had a senator put that bill on the table in 2018. And again here in 2020, it didn't even get a floor hearing. In fact, the senator who, let me just talk about the Senate Health Committee in Washington State. Between these 11 members, they have taken over $1 million. I did the numbers, over $1 million. Take the House and Senate committees together. I think there's about 28 members there. $2.5 million these people have taken from the for-profit. When you're talking about pharmaceuticals, you're talking about insurance, you're talking about hospital associations. There is a ton, and these medical lobbies are extremely powerful in state. Like the Washington State Dental Association is an extremely powerful lobby. And people know that if they go up against these lobbies, that money is not going to go into their campaign coffers. It's going to be turned against them for somebody who's challenging them. So we had the chairs of both the House and Senate health committees in Washington State refuse to give our whole Washington single payer bill a floor hearing. And those two chairs, it's amazing that you find when you look at the numbers for funding that the two chairs of those committees actually take more money than anybody else on the committee. It's almost as if we have the foxes guarding the hen house. So that's one of the reasons that I'm a supporter of campaign finance reform. I spent 4 years on the Washington State Democrat State Central Committee, supporting a resolution to pass Medicare for all, supporting a resolution. I wrote and passed the resolution to have our elected officials not take any money from the for-profit medical industry. These are things that when you go to rank and file Democrats, and I'm saying that because, I'm ostensibly a Democrat, I'd be further to the left if we had other options, but we don't. The people who want to consider themselves rank and file Democrats, they actually support all of these proposals. But the system is so awash in this corporate money that what we say, even on the state committee, when we are passing these resolutions unanimously, we still can't get, because our state Democratic Party is really just an arm of the DNC. We can't get any motion when it comes to forcing the hand of our elected officials, because the way the party operates and the way these campaigns for these particular candidates operate are much the same way. There's a ton of money shuffling going around from one campaign to the other. So we've got to get the money out of the system. We need campaign finance reform. And I truly believe if we could get the money out of the system and overturn Citizens United, which many Democrats benefit from. I mean, they may talk about wanting to overturn Citizens United, but absolutely they have benefited from it, the corporate Democrats in their campaigns. So we've got, it really comes down to our politicians are being bought off. They would reject that. They would say, no, this is just the way our system is set up. But you look at the money they take and you look at the votes they make, and it is an A to B connection. We've got to get corporate money out of the system.
Yeah, thank you. That was amazing. And you brought up some very important points, and we're definitely excited to see what kind of reforms you can bring to the nation in the future. So for the next few questions, these will be addressing the entire panel. So the first question is, in the recent past, blame for high drug prices has been alternating between pharmaceutical companies and pharmacy benefit managers, which is what Mr. Lowenthal was talking about earlier, with each pointing fingers at each other. So to address the PBM problem first, how can the government make sure that pharmacy benefit managers are putting their patients over companies? And what policies can we implement to make sure that corporate greed is not a factor? For this question, I'd like to start with Ms. Day first.
Yeah, definitely. And I am not an expert on PBMs, and I definitely would probably much rather have Justin or someone who has mentioned it before speak on it. But one thing that I did want to kind of go off of what Jason did say, is it okay if I do a little tangent, Emily? Okay. Great. So one thing I did want to say in terms of transparency and kind of dividing oneself from corporate interests, I think it's really, really important to even look at the traditional model of patient advocacy. So a lot of disease-specific groups will take 50% or even 100% of their funding from the pharmaceutical industry. And these are disease-specific groups that are supposed to be representing patients, but often all we'll see in terms of their point on drug pricing is a small paragraph on their website. And that's fundamentally showing their anti-independence to big industry. And I think that's really, really important for us and for the next generation of patient advocacy groups to really be mindful of where money is coming from. Because ultimately, if you are taking 50 to even 100% of your funding from the pharmaceutical industry, it's more like you're sort of a part of the pharma lobby rather than sort of serving and doing your job as to representing patients as a whole. So I think it's really important as a next generation to be aware of these conflicts of interest. And I think that, yeah, it's an area that's really tricky, but I do feel that with our generation will be a lot stronger if we do start saying no to corporate interests. And we at Health Advocacy Summit and its program, the Crohn's and Colitis Young Adults Network, we are one of the very few patient advocacy groups that is not funded by the pharmaceutical industry. We're completely foundation funded. And so we're hoping to set an example as to not accepting corporate interests and really being able to talk about these issues openly rather than being looped in because of industry members. So that's a tangent, but if anyone else would like to answer the PBM question, I'd love to hear from you.
Yeah,
Well,
thank you for, oh, sorry for interrupting.
Sorry, I just want to expand just a little bit about the state-based challenges on health policy and money and profit in healthcare. 6 of the 12 largest employers in Pennsylvania are healthcare related, right? So when they come to the table, right, they're bringing not just the size, and some of these are really big. I mean, we have a $23 billion nonprofit healthcare and health insurance entity, right? $23 billion, and it's a nonprofit organization, just the same as, with the same nonprofit status as my own, 13-person organization here, right? So I just want to really say, 2 things about, the really kind of our struggles for us at the state level to go on what Ms. Dave and Mr. Call said. Those people come to the table with a lot of money, right? This $23 billion nonprofit or some of these other entities, right? Not just have jobs, but a lot of resources and a lot of investment in keeping the system the same. The second thing that every elected official has in their district is a hospital, or many, I mean, most have. And those often are the largest employers locally, or one of the largest ones. No politician wants to lose their local hospital. When you talk about Medicare for All and some of these other things, they will immediately go to their politician, that's representing them and say, look, we'll close. You won't have a hospital in your district, if we're forced to go into some of these systems. So I just want to paint that picture about what this advocacy work is and why Ms. Dave's point about not, kind of taking money from certain groups is super important, because you really need to stand up against these really powerful entities and have direct conversations with lawmakers that that are going to compel them to change the system in a moment when there's a lot of these other forces in here. So we shouldn't give up, but we really need to know the extent of the forces in our own state and in our own local communities.
Yeah, sure. Would Mr. Lewinthal like to go next, and then we'll go to Mr. Call?
Sure, yeah, and I won't take up too much time. Just to talk about the pharmacy benefit manager aspect of this specifically, there are a lot of reasons to be concerned about pharmaceutical companies and their role in setting prices and in manipulating prices via rebates, which we've talked about. Pharmacy benefit managers, for those who are not familiar, are kind of middlemen in the chain. So you have a retail you have a pharmaceutical company, then you have this middleman who sets exactly what drugs are available and at what price, sells them to pharmacies like CVS, Walgreens, individual hospitals with their own pharmaceutical dispensation, and that's where a patient would try to get the drugs that they need. So pharmacy benefit managers play this important role in the middle. And because there's not a whole lot of regulation or even a whole lot of awareness of their role in the system, they can sometimes get away with some very opaque and bad behavior, I would say, in terms of how they manipulate prices. There are examples of pharmacy benefit managers instituting these gag clauses, which prevent pharmacists from counseling patients on alternative medications that may be just as effective but cheaper. And as somebody who organizes doctors and med students who themselves don't have a lot of training in talking about drug prices, but who part of their role is to counsel patients, it drives me crazy that this is a practice that's allowed. Sometimes pharmacy benefit managers will drive up prices and charge different prices to the big chains like CVS versus the smaller independent pharmacies, or use what's called spread pricing, where they'll charge state Medicaid programs or national Medicare a much higher price, and then pay pharmacies like CVS or Walgreens or smaller pharmacies a much lower price, and really kind of get that middle amount as profit. So there's a lot of opaque practices there. Ultimately, we need a solution or a group of solutions that deals with both pharmaceutical companies and PBMs at the same time. As you said, they'll point fingers at one another. Also, if you try to regulate one, the bad behavior shifts to the other, and vice versa. And I think it's a gargantuan task, and expecting states to handle it on a state by state basis when these pharmaceutical companies and PBMs are often national or at least regional in scope. It's a losing battle for states who are trying to cover patients with their Medicaid programs to be able to do that. And I really respect all the work that Patrick does fighting for the people in Pennsylvania, and Jason, for you in Washington. It's a really hard problem without some sort of national level intervention.
Thank you for the insight. Next, we would like to go to Mr. Cull.
I had a quick add-on to what Patrick said about the money in the system and the power of these giant companies, and to have your viewing audience understand that it is not just the for-profit healthcare industry, it's not just the pharmaceutical industry, it is the fossil fuel industry, it is the military industrial complex, anything that you can think of, and they often will go back to jobs. I mean, we have a diesel refinery, not to tangent too much. We have a diesel refinery that is opposed by the local community. It's opposed by the local tribes. It's impacting their water quality. It's impacting the whole of the Puget Sound. We oppose coal trains coming from Canada through Washington. The citizens of Washington said, we oppose this. But because of the power and the strength and the funding of the industries behind it, we have politicians falling back all the time. I've got 2 naval bases in my district. We have the politicians all the time falling back on, we need to keep these jobs here. And what we really need to do is say, we need elected officials at all levels to be more imaginative. If you're saying that with as many resources, as many human resources and powerful, motivated and compassionate people that we have in our country, that we can't do better than what we're doing right now. I mean, that's just the failure of imagination, but it is this corporate profit wall that is put up. And often, as Patrick said, often they use jobs as an industry. And I wanted to throw in here, this is one of the reasons I am supportive of a federal jobs guarantee, and we can probably talk about that a little bit later.
Great, thank you. And last but not least, Mr. Mendoza.
Well, this was an amazing set of pieces that came up. I want to string a couple of them together really quick, because from working on this drug pricing stuff for a while and just combating the healthcare industry, there's a few running themes here. One is, PBMs certainly are an issue in the system. Everything that Justin Lowenthal said is absolutely correct. The fundamental, if you boil it down to the very, very basics, problem that they create is that when they're paid, they're actually being paid off of the difference between what they negotiate and the high price set by pharma. So the higher pharma goes, the more money the PBM makes, and the higher the PBM pushes pharma, the more money pharma makes. So quite literally, if you squish one end, the other end gets fatter. If you squish the other end gets fatter, and they both work together. But the reason I bring that up is because everyone's talking about the money in politics, the money in patient groups, and it's so right. And they also put that money into trade groups. If you think of like the industries as almost a fist, right? If you, not to go like to aggressive, violent stereotypes, but go into aggression, and we looked at like, one fist punching another fist. What they've done is they've organized their industries for years. The pharmaceutical industry is only really 80 years old. It's not that old. But over the last 80 years, they've made sure that they have the right to donate money and be considered a person. They know that they have the ability to donate to and control patient groups that represent supposedly the voice of the people. They donate to and control medical organizations, not DFA, but other ones in the exact same way. And they oftentimes even reach into consumer advocacy spaces, like organizations that say that they are Patrick's organization and are not, and will do that same exact thing on the ground. So when you think about it, they make their fist as big as they can, right? They're one of the most profitable industries on earth. They make more money than oil and gas every year. They are able to take all of that money and put it into every single stream, and the politicians. so they can look like something that you absolutely can't beat. But remember, nothing's more powerful than people. So when we organize independent advocates, when we organize doctors who are willing to step up and talk about talk on behalf of their patients, when we elect officials who are willing to run without massive corporate power backing them and without PACs, and when we go out and we actually support and build consumer advocacy organizations that can look for the truth and report that out in a transparent way, and when students raise their voices and build up, we can actually win and we can beat them at every single level. This keeps happening in the States. Minnesota's already won a few things on insulin, where they've actually managed to get emergency insulin supplies, better transparency, and they're working on more stuff now to really make sure that folks with diabetes have better access to insulin. We're seeing this happen, of course, with the work that Patrick is talking about with the affordability boards, and we're seeing it happen at the federal level, where we're getting closer and closer and inching closer and closer to big reforms on vaccine access and other things, where folks have been pushing for years. So, just to say all of this is true, all of it is pretty terrible, and the system is set up against us. But if we band together, we organize, we think smart, and we completely don't fall into the traps of believing pharma when they say PBMs are the only problem, or PBMs when they say pharma is the only problem, or both of them when they say only insurance is your problem, but understand that all of them are from the same kind of, I guess it would be like a 12-sided die. Then you can understand that we really just have to organize enough power to fight back.
Thank you. Thank you for every single panelist's amazing insights on this issue. And our last question for today, which unfortunately, we're not able to get through all of the questions we prepared because this is not an issue we can just finish talking about in an hour and a half. But I would like to direct the question going back to foreign relations as well as Canada's policy. So for all the panelists, Canada's prescription drugs are significantly lesser in cost when compared to the drugs in the USA. And the same goes for many largely developed first world countries. So what policies can the United States implement from foreign nations to most effectively, have all patients receive treatment without worrying about the rising costs? If Mr. Kingdom wants to start, that'd be great.
Well, this is why I'm so excited that this event is co-hosted by Gen Z and Combat Patent Prices, because one of the things I'm really excited about is that younger generations aren't susceptible to the same old nonsense and propaganda that older generations are, right? So I was raised at a time where, the US, well, it was right at the end, but the USSR was supposed to be our worst enemy in the world. And it was this good versus evil kind of thing, right? And I think that unfortunately, a lot of older individuals kind of see the world in that way, right? It's either the United States or everyone else, right? And I think Justin and so many other panelists today have kind of really said, look, we all know that's not true, right? So I'm really hopeful that many of you who are listening, if you're younger, you're not susceptible to this us versus them kind of mentality, because the reality is that other countries are getting, much better benefits and much better impact. And that's partly because they made the change earlier, right? The United States really did hamstring itself when, it didn't post World War II pursue some of the more progressive policies that put countries on a better path, right? But I'm hopeful about this generation and younger generations that don't see the world in so much of an us versus them, particularly when it comes to issues like climate change or other kinds of things, because we can take the same kind of logic of climate change, right? Where everyone, many young folks have been on the forefront of that, realizing that we all need to work to save the world that we're in, right? And I believe that in the policy space, younger folks can look at healthcare and say, no, we need to bring these other ideas in. So, one of the things in closing, since this is on prescription drugs and I know we're out of time, but, one of the things we so often hear pharma say in these campaigns is, if you impose these policies, we're going to either pull out of Pennsylvania, we're never going to sell another drug, we're never going to develop another life-saving drug that might help like Ms. Dave and Crohn's and colitis, right? I mean, they really do these scare tactics, right? And you know what? It's not true. It's nonsense, right? I mean, they sell drugs in every country that negotiates prices, right? There's no evidence of pharma pulling out. They create new drugs because guess what? even if they are limited in the profit that they get, it's still profitable for them, right? So, even if you cap that profit, it still makes sense for them to develop a new drug, a new life-saving treatment. So I think we really need bold leadership, and I think that's going to come from younger folks who will stand up and call their bluff, just like so many folks are calling the bluff of big carbon and other folks and saying, look, something's got to change. So I really just want to put that out there, and thank you all for pulling this together today.
Thank you. Thank you for being an amazing panelist. And next, I would like to direct this question to the representative of our younger generation, Ms. Dave, and see if you have any insights that you want to add.
Yeah, definitely. I won't talk about Canada specifically, but I think the rest of the world as a whole. So the US is, I believe, the only country that does not have a health technology assessment. And so an HTA body basically develops a framework to evaluate particular prices as they pertain to their clinical efficacy. So, for example, the UK has NICE, and the US only has a nonprofit entity called ICER, the Institute for Clinical and Economic Review. And so basically it's ICER and a bunch of other organizations sort of against big pharma. And I don't want to say like head to head, but they sort of are I don't want to say only either, but they sort of are the ones that are trying to hold the pharmaceutical industry accountable for particular price increases when there is no extra clinical effectiveness shown. So I'm not saying that necessarily we should have an HTA body or we shouldn't, a formal one. I think it's very complex in the US in particular, but that is one area where we are a little bit behind in, is that we haven't had sort of formalized body that does sort of try to develop more framework based on clinical effectiveness and in more clinical effectiveness. So I think that's an area where the US differs vastly from other countries. And the other thing too is the pharmaceutical industry is making a lot of profit in countries like India and China. I mean, they are making enough profits to where we're just eating up the extra profits here in the US. And so I think that there's so much to think about there. And the other thing too is our generation, as Patrick said, we have so much power. And I really do feel like the more that we talk about it, the more we point out hypocrisies that are in our daily lives. I'm just going to give one example really fast. For example, Political Pulse, which is a health newsletter, they receive sponsorships from pharma, the trade group. And I wrote a 15-page ethical research paper about this during my senior year of college, but even media institutions are accepting funding from the industry. And what does that mean for our future in terms of independent journalism? So I think there's just, pharma has, as Justin mentioned earlier, has really infiltrated virtually every single part of our world, and they have so much power. And I think the more that we can pick out where they are and how they are affecting particular institutions, the stronger we'll get, and the more we'll be able to hold them accountable as a generation.
Yeah, I'm definitely excited to see you lead our youngest generation to combat these problems and make a whole lot of reforms to what we have today. So next, we would like to direct the question to Mr. Lowenthal and see any insights you want to add.
Yeah, I'd be happy to. What I will say, one of the aphorisms when we talk about drug pricing is that the prices in the United States are so high because they subsidize prices being low in the rest of the world. And I think that to a large extent is true. However, I think that also sometimes brings up concerns about, well, if we try to control or lower prices in the United States, will that cause prices in other areas of the world to go up and drugs to be inaccessible to populations elsewhere in the world? And we're not just talking here about, our first world, quote unquote, developed partners. We're talking about low and middle income countries who could be priced out. I think what we need to think about is, going back to something I said earlier, is how we incentivize and what we incentivize in drug development. So making sure that drug companies are developing drugs that are attuned to what's needed by the public's health, what's needed for global health interventions, what's needed to make the biggest difference for people's lives and for the economies otherwise being held down by some of these global epidemics, for example. We need to reward drug companies for not just going after the drugs that they can make the most profit on, but the ones that actually have the most clinical value for patients. And that's where health technology assessment becomes so critical. And I think there are many different solutions out there in terms of exactly how we set or ask pharmaceutical companies to set prices, whether we reward certain types of drugs all in a similar way, or we peg the price of a drug to the lowest price that's paid in the US by any firm in the US or internationally. There's a lot of different solutions to it. But I think what ultimately makes the biggest difference is when people are organizing to tell the stories of just how inaccessible these drugs are and what levels of illness and death and destitution these high drug prices cause people. And so I think that's why I was so happy to be invited to this panel and grateful to be among these folks. On the panel is, ultimately we're all in a position, particularly the youngest generation, to tell the stories of your friends, your family members, your communities. For us as doctors or medical students, being able to tell the stories of the patients we see who we can go to the ends of the earth to try to help treat, but if they can't access the drugs that'll make them better, there's only so much we can do. Telling those stories and telling them in a united and amplified way to put pressure on legislators, state and national and international bodies to make these changes, I think that's our best step forward.
Thank you. It's really amazing to have you on the panel today. Thank you for all your insights. Next, we would like to move on to Mr. Cull and see what other stuff you can add to what we've been discussing.
So I can't address Canada directly as the original question was, but I did want to echo what Justin had said a little earlier. When you go closer to the end, all the good points have been taken. And as Patrick was talking, I had written down something that he ended up saying not 2 minutes later about the, I don't know if you can read that, but call their bluff. I mean, really what it comes down to, if they're going to threaten to pull out and not provide these services, put them to the test. They won't do it. Patrick's absolutely right. They're not going to, they're going to take the profit where they can get it. And then what Justin had said is we have to humanize this struggle. Everybody knows, I mean, I gave you right at the beginning of this forum, I gave you two stories that were directly, my mother and my sister have these direct stories where they have been impacted by the for-profit health insurance industry. But everybody has those stories to some degree. And we have to humanize this. We have to put those stories in front of people, because that's going to help people connect. Oh, you know what? This happened to my brother. This happened to my kid. And that groundswell of grassroots activity is eventually going to make the changes that we need, hopefully sooner rather than later. I just want to thank you for holding Gen Z and I forgot the name of your organization for now, but the Combating Patent Manipulation. I so appreciate you putting this forum together. It is so enthusing for me as somebody who's going to turn 50 on my next birthday to know that I can look to the people behind me and think that the future is in good hands. My daughter turned 18 yesterday, and I want her to have the future that I felt like I had growing up. And I feel like that is slipping away sometimes. And then I turn around and see yourselves, and I feel like the swell of hope inside. The last thing that I want to leave you with is it's probably going to be a while before we get a Medicare for all system. I don't even think that they're putting it on the table in the House this time around, because they know they don't have the votes for it. So not to give a shameless plug, but a candidate like myself who supports Medicare for all, who doesn't take any corporate money, and like Angelica Duenas, who was going to be here, she ran last cycle. I got to know her in the last cycle. No corporate money. And there are so many good candidates around the country who want to fight for these principles and don't take that corporate money. Support us, help us get in office, and run for office yourselves. Run for your school board, run for your city council, your county council, run for your state representative. You guys can do it. And people like myself will be there to help you. And the very last thing that I would say is start a state single payer movement. We've got one going in Washington. You probably are aware of CalCare down in California. I know they've got a single payer movement in New York, in Massachusetts. Start a single payer movement. If anybody wanted to contact me and say, can I see your legislation? I will hand you the legislation and say, modify it for the needs of your state. But here we've got a 67-page bill. It's written, it covers all the bases. It takes the corporate money out of it. It makes sure everybody is covered, and it addresses prescription drug costs. So again, thank you so much. And panelists, it's been wonderful to hear you also.
Thank you. Thank you for that. And it's, wow, 67 pages of bills that address every issue that we just talked about. That's amazing. And we definitely are excited to see you being elected in the future and make some changes to the policies that we have today. And last but not least, we would like to end our conversation with Mr. Mendoza and see if there's anything else you want to add to the conversation.
This was amazing. This conversation is fantastic, and definitely I think I'm leaving also with a sense of hope about really seeing folks mobilize on this stuff as well. Every movement's incredibly important, and so many of these entities are the same folks who really just want to hoard all the wealth and make sure that the rest of us have to kind of run around for the scraps. But to the Canada question and kind of diving in there, there's a couple of policies I just think really are worth pointing out. Justin was talking about a whole category of them that I would lump under reference pricing, the idea that we look across the board, see what other people are paying, and ask our own companies, why are you charging us more? And you can do that any millions of ways that can be done. Representative Ro Khanna actually had really good legislation last year that tied the reference price to their patents and said, if you're charging us more than the reference price that we look at, we're going to tell you that your patent is no longer valid. Not literally, it would actually pay them, but they would only make money off of the sale of the drug by another company. And competition will drive down prices. If you have 2 competitors, really you need 3. But once you get to 3 competitors, you can drive down prices of a drug, for most drugs. And then the other piece that I think is worth pointing out in this is really taking a look upstream. And I think Combat the Patent Prices is doing this. When you're looking at institutions like universities or the National Institutes of Health or others that are directly doing the research that leads to those drugs, there are really simple policies in the contracts that we sign. When a university develops a drug and discovers it, they sign over the right to produce that drug to a company. And they can literally tell them, if you charge more than X, Y, or Z, you have to come back to the negotiation table with us and we can tell you whether or not you get to use our technology. Or they could tell them, make sure it's available at cost in these countries. If you don't, again, you have to come back to the table and work with us. And right now, as something that folks can do as an action, there is an agency called the National Institute of Science and Technology, or NIST, that is trying to change a federal rule that, as it is written, would allow the federal government to have that exact conversation with companies when the price for a drug is unreasonable. They want to change it so that the unreasonable language is struck out of the rule. They want to make sure that the US government has no power to step in when taxpayer dollars have been invested heavily in these drugs to say, hey, that price is unreasonable for patients. Notably, the government's never done it, but the rule exists and it could be used with enough pressure. And if the folks who are pushing for this change win, we won't have that on the table anymore. And we'll have to find other ways to do it. So there's moments like that. There's policies that are so nuanced and so specific that, if I actually read the text too, I think we'd all be sleeping. But those policies are so important because if we can get rid of the patent problem for a number of drugs, we can make sure there are generic versions or biosimilar versions of medicines available much quicker so that folks can have access to them and competition can drive down prices. But anyway, I just want to say, this has been awesome. And I think, the movement pieces of this are all what's so essential. Even winning on these tiny, minute policy details, the more pressure politicians have, the better we're doing. And the more folks who aren't just beholden to massive corporate interests, the better we're doing in terms of getting this done.
Thank you, Mr. Mendoza, and thank you to every single panelist for coming today. And we really hope to have more of these very productive conversation in the future. And for the audience members who are watching, be sure to post about this on your social media to bring more light to these important issues and to bring more support to these candidates who are running for Congress who will actually make changes on these policies and improve people's qualities of life. Thank you all for taking a part of this Patients Before Profits event. Thank you to Gen-Z and Combat the Patent Prices for hosting this event. And thank you so much for being on the panel again. Hope you have a nice rest of your